So we're going to start with an introduction to approach this subject. We will follow with the objectives of our work, the materials and method used. Afterwards, we will explore the results and discuss them before concluding. Let's start with the introduction. The definition of borderline ovarian tumors is anatomopathological and is based on the combination of 4 histological criteria: multisatisfaction and epithelial budding, increased mitotic activity, cytonuclear atypia, and absence of stromal invasion. Borderline ovarian tumors represent 15 to 20% of ovarian tumors and concern young women for whom fertility preservation is an important therapeutic issue. Let's cite the objective of the work. First, is to focus on the difficulty of clinical, paraclinical, histological, and therapeutic diagnosis for this type of tumor to establish a therapeutic patrol according to the data of the literature. Let's pass to the material and methods. It's a retrospective study of 20 cases of TBO collected in the departments of Gynecology Obstetrics 1 at the Hassan II University Hospital of Fez over a 10-year period. Shall we pass to the results? First of all, the average of our patient was 36 years with extreme ranging from 19 to 68 years. More than half of our patients were nulliparous. The average delay of consultation of our patient was 15 months. Abdominal distension and pelvic pain are the most frequent signs of cold. Concerning the size of the pelvic mass, 6 patients have a tumor size inferior to 10 centimeters, 8 patients from 10 to 20, and 3 patients superior to 20 centimeters. Size is difficult to appreciate due to abdominal distension in 3 patients. Concerning the malignancy criteria, acids were found in 2 patients. No patient had a clinical bilateral mass. 2 patients had a fixed mass in relation to the deep plane, and 6 patients had a mass of hard consistency. Concerning the complementary investigation, 80% of the patient had a palpable abdominal pelvic mass with an average size of 15.3 centimeters. Ultrasound was performed in all our patients and confirmed the existence of pelvic mass, which was cystic in 60% of the cases and solid and cystic in the rest. This is an ultrasound image of our patient made in our gynecology department, try ovarian cyst of 112 millimeter biloculated with intercystic vegetation, left ovarian cyst of 17 millimeter with echogenic contents. This is one also ultrasound image showing a multilocular cyst image with fleshy compartments and taken color and pulse Doppler. 7 of our patients have benefits from a CT scan. A suspicious aspect of malignancy was found in 6 patients. None of our patients had a pelvic MRI. This is a CT image scan at Hassan II University Hospital of Fez. Solid cystic mass, most probably of right ovarian origin, was limited in multilocular. Concerning the tumor markers, 5 of our patients has a normal CA1 125. Concerning the treatments, the need of a laparotomy conversion was just in view of the difficulty of manipulating the cyst, given the multiple adhesion in 1 patient, the operative difficulty and accidental rupture on the cyst with the release of a thick mucinous liquid in the 2nd patient. The conservative treatment consisted of a unilateral adenoidectomy in 7 patients, ovarectomy in 1 patient, and 1 patient had a cystectomy. All patients who underwent conservative treatment was nulli gravidia. Their ages were lower than 40 years. Concerning the radical treatment, 8 patients underwent radical treatment. The surgical treatment consisted of a total hysterectomy, bilateral adenoidectomy, omentectomy, and biopsy of the right and left GPC. 5 patients were multiparous, 2 were nulliparous, and 1 patient was possiparous. Concerning the lymphadenectomy, two patients benefit from additional iliac courage, but for the presence of a silver grade 1 microinvasion site in one patient. The second patient had a microscopically suspicious appearance at the time of surgical exploration. 12 tumor was classified as stage 1, 8 classified as 1A, 1 classified 1B bilateral, 3 classified as 1C as stage of ectocystic vegetation, and 4 tumors were classified as stage 2. 2 classified as 2A, tumor extending to the tube, 2 classified 2C, tumor extending to the pelvic organ with acid or ectocystic vegetation, and 4 tumor were classified as stage 3B, no tumor was classified as stage 4. Histological section made by an anatomopathology department showing borderline mucinous tumor of the ovary with papillary projection with nuclear pseudostratification. The second section shows a borderline serous tumor of the ovary. Let's pass to the discussion. Concerning the frequency, borderline tumors of the ovary represents about 15 to 20% of all epithelial ovarian tumors with an incidence of 1.8, 4.8 per 1,100 women per year. The increase of the incidence of BTOs of the ovary has been observed over the past decade worldwide with a slide in the incidence of ovarian cancer. Concerning the age, patients with borderline ovary tumor are generally younger than women with epithelial ovarian cancer. The mean age of our patients was 36 years. In other series, the average age varied between 19 and 60 years. We'll pass now to the circumstance of discovery. The most common symptom in BPH is pelvic pain, followed by increased abdominal volume with or without the perception of an abdominal mass. Menorrhagia observed in 3% to 17%, depending on the series. Pregnancy is a circumstance of discovery in 2% to 7% of cases. It does not seem to favor the occurrence of TBO, nor to worsen the prognosis. However, the therapeutic implication may be delicate. The TBOs usually have a large volume, 15.3 centimeters in our series and 15 centimeters in other series. Clinically, borderline ovarian tumors have a non-specific symptomatology, which is common to all ovarian tumors. The only thing to think about is BTO in front of a pelvic mass is quite important size, is relatively young and often healthy women. Concerning the use of ultrasound, it's the first-line examination to be performed for the primary detection of any adnexal mass, but not specific sign of borderline tumors has yet been established. However, the main sonographic characteristic of TBOs in the literatures are a smaller size than malignant tumor, presence of vegetation or papillary projection, and hypervascularization, decreased volatility and resistance index. This is an ultrasound image showing mucinous borderline tumor of endocervical type, solid multilocular tumor with a large number of endophytic and exophytic papillae, and borderline serous tumor, solid multilocular tumor with papillae and necogic intercystic fluid. Let's pass to the use of CT scan and MRI. MRI is recommended as a second-line procedure to characterize ovarian lesions that remain undermined after ultrasound or to link a large pelvic mass not to explore on ultrasound to its ovarian origin. CT and MRI are more efficient for the research of pejorative signs, the presence of peritoneal implants, invasion of the abdominal pelvic wall, and the presence of adenopathies. This is an actual CT section of a borderline mucinous tumor, showing a large multilocular cyst with irregular and thick internal septa. The second one is a sagittal T2 weighted section of a borderline mucinous tumor showing a large unilocular cystic mass without internal septa. Concerning the tumor markers, the main marker used is CA125. This marker is less sensitive for the detection of borderline tumors than for invasive carcinoma. In our series, the CA125 assay was negative in all patients. Concerning the anatomopathology, series TBO are the most frequent in all series, followed by mucinous tumors and then the less common histological type, namely endometrioid OBRRT, clear cell OBRRT, and transitional cell bladder tumor. It is necessary to look for the presence of microinvasion, invasive or non-invasive peritoneal implants, and the presence of a micropapillary component, which influences the prognosis of OBRT. Concerning the treatment, we'll start with the surgical treatment. There are three stages of in the surgical procedure. First of all, careful exploration of the entire abdominal and pelvic cavity, the realization of extemporaneous operative examination when the tumor is macroscopically suspicious, and the realization of the surgical extension assessment called staging surgery. In our series, the extemporaneous examination performed in 12 patients with a concordance with a definitive examination in 100% of the cases. In the literature, the concordance of extemporaneous examination with a definitive examination is order of 16 to 70%. Only a formally positive result can be taken into account. If there's any doubt, it's necessary to wait to the definitive histological result. We know the study done in France that 38% extemporaneous examination was mistaken for benign tumor and 2% was considered as malign tumor. Concerning the stratification, all series show that the most patients are classified as stage 1 and particularly 1A. Concerning the therapeutic attitude, especially the choice between conservative or radical treatment, there has been a considerable increase in the current use of extemporaneous examination in comparison with the study done on TBO in our training in 2008. No patient had benefits from a conservative treatment versus 40% in our study. Conservative treatment will consist of cystectomy, oophorectomy, or unilateral adenexectomy, omentectomy, and multiple biopsies, peritoneal cytology. Unilateral adenexectomy is the ideal conservative treatment for BTO. Cystectomy significantly increases the recurrence rates up to 30% in some series. Cystectomy should be reserved for the least affected ovary in bilateral forms. Cystectomy significantly increases apertomy. The radical treatment will consist of a bilateral adenexectomy, total hysterectomy, omentectomy, resection of microscopically suspicious lesion, and multiple biopsies with cytological sampling. Concerning the lymphadenectomy, pelvic and lumbo-aortic courage is not considered necessarily. Lymph node involvement does not decrease survival. Only clinical suspicious enlarged lymph nodes should be removed. Concerning the adjuvant treatments, the majority of studies agrees that adjuvant treatment, chemotherapy or radiotherapy, does not improve patient survival in borderline ovarian tumors. Some publications have even shown that its toxicity may be more detrimental to patient survival than its effectiveness. However, it is proposed in the majority specialized centers in case of peritoneal invasion and must be discussed on a case-by-case basis. The study of TOR shows that radiotherapy is used in 2.2% of patients for the presence of postoperative tumor remains. Concerning the indication, the therapeutic indication of borderline ovarian tumor essentially depends on TBO, staging, the patient's age, and her desire to become pregnant. For patients with a stage 1 tumor and wishing to preserve their fertility, and the diagnosis of TBO has been established by extemporaneous examination, we will have recourse to a conservative treatment with a unilateral adenexectomy, which is preferred to the cystectomy. Staging surgery consisting of peritoneal cytology, a mastectomy, and multiple biopsies is always required, and there is no indication for lymph node dissection. In the diagnosis of TBO was not initially established by extemporaneous examination, restoring surgery will only be indicated when there is a macropapillary component and or if peritoneal exploration was initially incomplete. For patients with a stage 1 tumor not wishing to preserve their fertility, if the diagnosis of TBO was established by an extemporaneous examination, we will either have recourse to a radical treatment with bilateral adenexectomy or conservative treatment with unilateral adenexectomy. Hysterectomy is not systematic. If the ovarian borderline tumor diagnosis was not initially established by an extemporaneous examination, either a surgical adjunct of bilateral adenexectomy and for peritoneal staging was used. Either we will use content with simple monitoring. For advanced stage tumor, radical treatment is preferred except for young patients wishing to preserve fertility, or the therapeutic indication will depend on the presence or absence of an invasion peritoneal implant. In the absence of an invasion peritoneal implant, conservative treatment is possible. In the presence of this invasion peritoneal implants, radical treatment should be initiated with the use of adjuvant chemotherapy. Regarding borderline mucinous ovarian tumor, the treatment is identical to serous tumor with an addition, a systematic appendicectomy if it's in an intestinal tumor, if conservative treatment is indicated, preferring an annexectomy to a cystectomy. Results of peritoneal restaging surgery if an anthroepithelial carcinoma component is assessed. Indication of a laparotomic abort because the bigger size of the tumor, resort to digestive exploration if we face a bilateral tumor, and discuss the case with the referring pathologist if the peritoneum is also affected. Discuss a complete peritoneal resection if a peritoneal pseudomyxoma is associated. Concerning the prognosis factor of borderline tumor as shown in our study are the therapeutic choice with a recurrence rate that is higher in case of cystectomy compared to ovarectomy, and that is significant decrease in adenexectomy, the tumor stage, the histological type, presence of micropapillary components, rupture of the cyst intraoperatively, and the presence of peritoneal implants. Concerning the surveillance, conservative treatment needs a closer follow-up, every 4 months for 1 year, then every 6 months for 2 years, then annually. For radical treatment, it needs a surveillance every 6 months for 2 years, then annually. To conclude, borderline ovarian tumor most often affects young women. The majority of them are diagnosed in early stage. The choice of the appropriate treatment for each patient is a great challenge for the practitioner. The indication for fertility preservation are expanding given the low risk of recurrence and the good prognosis of BOT. However, each case must be analyzed by the multidisciplinary team. Thank you.
Dr. Martin, we will proceed with the next presentation of yours, Doctor.
Yeah, shall we start?
The granulosa tumor of the ovary, about 7 cases. Is that the next presentation?
Yes, it's the ovarian granulosa tumors.
Okay, share the screen now.
Shall we start?
Yeah, let's start.
Dear colleagues, honorable audience, allow me to present you a brief overview of our work entitled Ovarian Granulosa Tumor, about 7 cases. This work reports the experience of the Service of Gynecology Obstetrics 1 of Hassan University Hospital based in Fez. To approach the subjects, we will follow the following plan. We will start with an introduction, cite the objective of this work, the materials and method used. Afterwards, we will explore the results and discuss them before concluding. Ovarian granulosa tumors are rare, representing 0.6 to 3% of all ovarian tumors and 5% of ovarian malignancies. They arise from the stroma and sex cord of the ovary. There are 2 histological forms, the adult form and the juvenile form. The clinical picture is dominated by the tumor syndrome and the endocrine syndrome. The anatomopathological study has a key role in the diagnosis management. There are numerous therapeutic means, and the choice of treatment depends essentially on the stage, extension, and evolution of the tumor. Our work has as objective first to analyze the epidemiological aspects of the tumors of the granulosa of the ovary, then to study the clinical, paraclinical, and histological characteristics, to describe the therapeutic and evolutionary methods, and finally to study the prognosis factors. Our study is a retrospective study over a period of 4 years and a half, between January 2017 and May 2021, carried out in the Department of Obstetrics and Gynecology 1 of Hassan University Hospital, Fez. During this period, 7 patients were treated for tumor of the ovarian granulosa, excluding non-operable files and patients without histological evidence. The data collection was carried out from the register of the archives and HOSIX. Let's pass to the results. Concerning the epidemiological data, the average age of our patients was 48 years, with extremes of age ranging from 32 to 64 years. The peak of frequency is between 40 and 50 years, with the predominance of women over 45 years old. As shown by the diagram, there is a predominance of genetically active patients with a percentage of 57.2%. Ovarian granulosa tumors are frequent in multiparous women with a percentage of 57%. Turning to the clinical diagnosis, the circumstances of discovery reports by our patients were dominated by abdominal pelvic pain in 85.71% of cases. Abdominal pelvic mass was reported by 71.42% of cases, and abdominal distension and metrorrhagia was reported by 28.57%. Concerning the clinical examination, for the clinical examination, the tumor syndrome was the most found, represented by an abdominal pelvic mass in 5 patients, 71.4%. Acids in 1 patient, increased uterus size in 1 patient. The endocrine syndrome was represented by hirsutism in 1 patient and high blood pressure in 1 patient. Concerning the imagery, moving on to a paraclinical diagnosis, abdominal pelvic ultrasound was performed in all our patients. 57.14% of the patients had thoraco-abdominal pelvic CT scan. 28.57% of patients have a pelvic MRI. For the abdominal pelvic ultrasound, the tumor size was specified in all patients with an average of 14.12 centimeters, varying between 7.3 and 30 centimeters. The criteria of malignancy was thickened wall in 1 patient, multilocularity in 4 patients, partition on Doppler in 3 patients, and peritoneal effusions in 2 patients. Here is a pelvic ultrasound image performed in our university hospital of a patient in our series showing a right lateral uterine mass with a septum and a tracystic bud measuring 8.2 cross 4.8 centimeters. For CT and MRI, a suspicious aspect of malignancy was found in 6 patients. A solid cystic aspect was found in 4 patients. The multiloculated character with presence of a thick partitions in 1 patient and the enhancements after injection of contrast medium in 1 patient. Here are 2 CT scans performed in our university hospital of a patient from our series showing a pelvic mass with a double components, mostly cystic, with endocystic tissue buds enhanced after contrast. The mass measures 17 cross 22 cross 12 centimeters. For tumor markers, estradiol was measured in 6 patients returning negative. Inhibin was measured in 7 patients returning positive for 1, and anti-Müllerian hormone in 2 patients returning negative. For tumor size, the average diameter was 14.12 centimeters, with extreme ranging from 7 to 30 centimeters. For patient had a size superior to 10 centimeters. The immunohistochemical study was performed in all our patients. Inhibin is the most found marker with a percentage of 85.7% of cases, followed by caltrinin with a percentage of 42.8%, CD99 and vitamin with a percentage of 28.5%, and finally desmin with a percentage of 14.2% of cases. The endometrium was explored in all patients, showing the presence of glandular polyp without atypia in 1 patient, endometrial hyperplasia without atypia in 2 patients. The exploration came back without abnormalities in the other patients. Four patients had stage 1A, 2 patients had a stage 3A, 1 patient had a stage 3C, and no patient had a stage 4. Concerning the therapeutic management, especially the surgical part, 1 patient had a conservative surgery which equals to 40%, and the other hand, 6 patients had a radical surgery with equal 86%. For chemotherapy, 3 patients received chemotherapy. For stage 1A, no patient received chemotherapy. Concerning the chemotherapy, for the protocol used, 2 patients received a B protocol, which is equal to 67%, and 1 patient received a carboplatin protocol. The median number of treatment received was 3, with extreme of 2 to 9 treatments. The mean follow-up is 45 months. The median relapse-free survival was 25 months. Concerning the prognosis factors, correlation of prognosis factor to overall survival. For prognosis factor, a statistically significant association between FIGO stage and overall survival was noted, with better survival for patients with stage 1. Correlation of prognosis factor to progression-free survival. However, none of these factors, age, tumor size, size of surgery, chemotherapy, protocols, and number of courses showed a significant association with progression-free survival. Let's pass to the discussion. The average age of foreign series ranged from 43 to 49.6 years, which is consistent with the average age in our series of 48 years. Hormonal status has been studied in most of the series, but the results remain variable. Our study shows a predominance of GGT in generally active patients, which is consistent with the series of Elus and Lai, and inconsistent with those of Sharoni and Shirley. With regards to GTT, multiparity seems to represent a risk factor, which is proven in all series and is consistent with our results. Concerning the circumstance of discovery, in the present series, abdominal pelvic pain was the main reason for consultation found in 86% of the patients, which is consistent with Aluza's series and inconsistent with Shura and Magnoli series. The endocrine syndrome was dominated by metrorrhagia, which is consistent with the series of Mangeli. Concerning the tumor markers, the hormonal activity of granulosa tumors allows the use of a variety of tumor markers for diagnosis guidance and postoperative surveillance. The main serum tumor markers are inhibin, estradiol, and anti-Mullerian hormone. Verification of the absence of elevation of AVP, beta-ACG, and total ACG is essential preoperatively to eliminate the presence of malignant germinal type tumor contingents. For anatomopathology, here is a microscopic image of an adult granulosa tumor. It is as well limited cystic mass of heterogeneous appearance, tissue, and hemorrhagic on section. On the microscopic level, here is a slide made in the anatomopathology laboratory of our hospital, showing a tumor proliferation made of non-joint cell arranged in a diffused sheet. The tumor cells have overnuclei with fine chromatin. The main marker expressed by GTO cells are vimentin, CD99, and smooth actin. Inhibin is the most intensely positive marker. The other markers are AE1, AE3, S100, desmin, calritin can be positive, but is less specific than inhibin. Concerning the therapeutic management, in our series, radical surgery was the most common, which is consistent with the results of other series. Lymph node dissection was performed in 14% of the patients with negative results, which is consistent with the literature. Therefore, lymph node dissection has a very limited place. Secondly, chemotherapy in our series. The percentage of patients who received chemotherapy is consistent with the literature. According to the guidelines for rare malignant tumors of the ovary for stages 1, 2, and 3, for young women, conservative surgery is possible, provided that it is combined with curettage of the endometrium, complete exploration of the peritoneal cavity, multiple biopsies, and careful examination or even biopsies of the contralateral ovary. After the age of pregnancies, hysterectomy with bilateral adenexectomy completed by the same workup procedures appears to be less likely to result in recurrence and eliminate the risk of secondary hormone-induced endometrial cancer. For stage 4, we proceed for maximal tumor eradication excision. For stage 1, 2, 3, if complete surgery, RO and stage 1A and stage 1B, no indication for further treatments. If stages 1C to 3 and incomplete surgery, adjuvant chemotherapy with 4 courses of BIP is indicated. If stage 1C to 3 and complete surgery, adjuvant chemotherapy with 3 courses of BIP is indicated. For stage 4, a complementary treatment based on 4 cycles of BIP is indicated. For relapse progression, Surgical revision should be systematically discussed if the patient has not been previously treated with chemotherapy. 3 to 4 courses of BIP or 6 courses of carboplatin are proposed. If the patient has received previous BIP chemotherapy, second-line chemotherapy is indicated. Because of the risk of very late recurrence, long-term monitoring is mandatory. Clinical, biological by tumor markers, and radiological by CT scan if the stage is higher than 1 or if the markers increased, and by pelvic ultrasound in case of conservative treatment. To conclude, granulosa tumor are rare malignant tumors, but it's important to be aware of them when faced with an ovarian tumor. Treatment is based on surgery, which is immediately radical for older women and conservative for younger women wishing to become pregnant, and chemotherapy depending on the stage. For advanced stages, chemotherapy based on BIP or carboplatin paclitaxel remain the basis of treatment. The prognosis remains relatively favorable and surveillance must be prolonged because of the risk of very late recurrence. Management is multidisciplinary. Thank you.